Welcome to today's NCPDP webinar, Preparing for the Medicare Part D Requirements for ePrescribing and Long-Term Care. Today's webinar is sponsored by Millennium Pharmacy Systems, Inc. The webinar today will provide an overview and history of ePrescribing and the related federal regulations and associated standards. At the conclusion of today's webinar, there will be time for Q&A. During the webinar at any time, you can type questions in the chat window, and we will address these questions at the conclusion of the webinar. Today's webinar features continuing education credits for pharmacists, pharmacy technicians, and nurses. At the end of today's webinar, the CE evaluation form will be emailed to all attendees on the attendee list with instructions to sign and complete the form and return it via email no later than Tuesday, June 17th. This information can also be found in the chat window during today's session. First, I'm going to go over some CE information. We have our speakers today, Andrew Morgan and Gary Schottmer, have no potential conflicts of interest associated with this presentation. Our pharmacy and pharmacy technician accreditation comes from ACPE, and our nursing accreditation for today's webinar is from ANCC. Our program objectives for our webinar today are to recognize the requirements of the Medicare Part D ePrescribing program, identify what the MMA transaction standards are for the Medicare Part D ePrescribing program, define ePrescribing under MMA, assess the value of ePrescribing brings to your organization, and to restate the new Medicare Part D requirements for ePrescribing and long-term care. Our speakers today will be Gary Schottmer. Gary is a registered pharmacist and Senior Vice President and Chief Information Officer at Advanced Pharmacy, a long-term care pharmacy provider specializing in remote automated dispensing. Prior to joining Advanced Pharmacy, Gary was the CEO of RNA Health Information Systems, a developer of LTC pharmacy computer applications. While at RNA, he was a co-investigator in the 2006 CMS ePrescribing pilot for long-term care. Gary is a member of NCPDP, where he co-chairs the long-term care. I'm sorry. Excuse me. Who's ever typing, can you please mute your phone? Where he co-chairs the long-term care and post-acute care work group and participates in the ePrescribing and related transactions work group. Co-presenting today with Gary will be Andrew Morgan. Drew works for the Centers for Medicare and Medicaid Services, CMS, where he works on the Health IT Initiatives Group in the Office of eHealth Standards and Services as the ePrescribing lead, and is also the lead for the high-tech EHR Incentives Program appeals process. Drew joined CMS in August 2005, where he was the project officer for the 2006 CMS ePrescribing pilot. Drew is involved with the agency's efforts to promote the adoption of ePrescribing for Medicare Part D. Drew has worked on all ePrescribing final rules and physician fee schedules where ePrescribing standards were either adopted or updated for the Medicare Part D ePrescribing program. Drew is a member of NCPDP, where he participates in the ePrescribing and related transactions work group. At this time, I will now hand the presentation over to Gary Schottmer, who will begin today's webinar.
Hi, thank you, Wendy, and good afternoon or good morning to all, depending on on what part of the country you're finding yourself in today. It's a pleasure to be able to do this presentation, and again, we appreciate all of your attendance and participation. First, starting out the agenda, what we're going to do, we're going to do a quick overview of ePrescribing. Then we'll get right into the regulatory requirements. Also, ePrescribing specific to long-term care, talk a little bit about next steps, and then we'll address the questions that have come in through the chat process. Next slide, please. And next. Okay, first, start out here. Just take a moment and review the CMS definition of ePrescribing. This is found in Title 42, Section 423-159. But ePrescribing means the transmission using electronic media of prescription or prescription-related information between a prescriber, dispenser, pharmacy benefit manager, or health plan, either directly or through an intermediary, including an ePrescribing network. ePrescribing includes, but is not limited to, two-way transmissions between the point of care and the dispenser. And I think probably for what we're talking about specific to long-term care, that last sentence is a critical portion of this definition. Next slide. This diagram basically shows kind of the process flow for ePrescribing. I'm not going to spend a lot of time here. I think as practitioners, most all of you are somewhat familiar with most of this. One thing I do want to point out, though, as far as the process flow, particularly with the electronic messaging that is defined in the rule, if you see just below the prescriber and the patient, you've got the ePrescribing vendor. And what is diagrammed here is the process whereby from the prescriber and the prescriber's ePrescribing system, either an X12 270 eligibility inquiry or an NCPDP formulary and benefit inquiry can be sent directly to the processor or the PBM to really ascertain the eligibility and or coverage for a particular drug before that prescription is ever sent and routed to the pharmacy. Then, once that is determined, then following the process here, the electronic prescription goes to the pharmacy. The pharmacy then dispenses the medication either back to the patient or to the care facility. And then across the bottom just shows really the claim cycle, where the claim is sent to the PBM via a NCPDP D.0 telecom claim, and the electronic remittance advice then comes back as an X12 835. Next slide, please. What describing here a little bit is the various message types that are part of script version 10.6. And starting at the top and looking at it to a large degree from a long-term care standpoint, first, the standard accommodates a census message. This is generally a one-way message from the facility to the pharmacy, which would include the ADT information regarding allergies, diagnoses, and payer information regarding a specific patient or resident. Then moving down, the next arrow shows the e-prescriptions, the two black arrows. The top one represents a controlled substance where that message is going to originate directly from the prescriber, and this is for compliance with the DEA's rules regarding electronic prescribing of controlled substances. And then for non-controlled substances, the message will most likely originate within the care facility, and those could be new orders, a change of an order, or a discontinuation of an order. And the specific script messages would be new RX and cancel RX. And then in the event of a changed order, the process would be basically the pharmacy would receive electronically a cancellation on the original order, and then, and then a new Rx for the new order. Also, with the bidirectional functionality of script, once the pharmacy processes the order within the pharmacy, a message would go back to the facility's EMR system. It's called the Rx fill message. That's going to have dispensing information about exactly how the order was processed within the pharmacy. So in the event of a generic substitution or possibly a therapeutic interchange, the pharmacy is going to electronically notify the facility exactly what medication is being dispensed and what the directions are going to be for that order specific to the product that was being dispensed. The last message type here on the screen shows the messaging going from the facility to the pharmacy. This is what's called a resupply message, and this is the message that would be sent in the event or when the facility is wanting to order a refill of medication for a particular order for a particular patient. Next slide, please. Okay, this slide is just to diagram. I mentioned a little bit about the patient medication history. This slide is kind of to demonstrate three of the use cases for a message called patient medication history. Starting on the left, what's diagrammed here is that a prescriber can send a request to the patient's payer and receive directly from the payer the medication history for a particular patient. Then in the lower right, also a facility, a hospital, a health center of some sort can also send a request directly to a pharmacy and get the up-to-date medication profile for a particular patient. And lastly, here on the upper right is basically a medication history sharing between two care facilities. And this would be done in the event of a discharge and from one facility and an admission into another facility, where the discharging facility can share the medication profile for a patient directly to the admitting facility. Next slide, please. Okay, benefits of ePrescribing. And I'm going to run through these relatively quickly here. First of all, compliance with regulatory requirements. It is supportive of efforts to improve patient standard of care. It increases administrative efficiency within care settings. It is welcomed by patients. It is safe and secure. It is currently allowed in all 50 states. Next slide. ePrescribing and who is involved. Certainly the prescribers, whether it's individual practitioners, whether it's clinics, hospitals, or other provider associations or care centers, pharmacies, certainly software vendors are actively involved, and that would be both the pharmacy software and also the EMR software that would be used within the facility. Trade and professional associations, lab and ancillary services for interoperability, state and federal government, standards development organizations. These are the organizations such as NCPDP that develop the communication standard for these messages. Terminology and code set organizations. These are the organizations such as Rxnorm or SNOMED that define the coding nomenclatures, say for drugs or for allergies. So just the various ways of coding some of the information that goes in these records. Certainly health plans, payers, and processors, and also the intermediaries And by the intermediaries, these would be the organizations that sit between the prescriber and the dispenser that actually do the switching of the electronic prescription from the point of origin to the point of destination. Next slide. Some of the successes with ePrescribing. First point here, it says nearly everyone is ePrescribing with the exception of long-term care. That's somewhat of a subjective point, but from the SureScript's 2013 National Progress Report, they're reporting to support the nearly everyone portion here. 96% of internists are electronic prescribers, 85% of family practitioners, 81% of endocrinologists, cardiovascular doctors, about 80%, and about 78% of pediatricians. So good adoption on the prescriber side, with the exception really of long-term care, where not quite as much endorsement at this point in time. How long have these folks been doing ePrescribing? Again, from the SureScript 2013 National Progress Report, back in 2004, when ePrescribing was just starting to get off the ground, about 4% of physicians had ePrescribing capabilities. By 2010, that had increased to approximately 36%. 2011, 58%. And then in 2013, we had progressed to the numbers that I had just shared. 93% of community pharmacies can accept ePrescribing. That's SureScript's 2012 number, and in 2013 that had increased to 95%. Also, these next percentages are all from SureScript's 2012 progress report. 25% increase in physicians that were capable of ePrescribing. That's 2012 as compared to 2011. Also, a 38% in the increase, or 30% increase of electronic prescriptions, and that's again comparing 2012 to 2011. Also interesting here, if we compare the electronic health record as opposed to a standalone ePrescribing system, of those physicians that were, or prescribers that were ePrescribing, 13% were using standalone systems. 87% were using ePrescribing as a module within their EHR or EMR system. Next slide, please. Also here, that I mentioned that in 2012, electronic prescriptions were up at a percentage of 38%, and that there were a record of 788 million electronic prescriptions in 2012. Also, in 2012, 44% of all prescriptions dispensed were routed electronically, and that is up from 36% during 2011. Prescription benefit information responses increased by 33% in 2012, and also in 2012, nearly half of all patient visits, specifically 48%, generated an electronically delivered medication history, and that's up from 31% of patient visits in 2011. Next slide, please. All right, and with that, I am going to turn the presentation over to Drew to speak more specific to the regulatory requirements.
Thanks, Gary. Next slide. So I'm going to just go over some of the highlights of the timeline. This is the timeline of when we first final rule that where CMS adopted standards for ePrescribing for Part D. So in 2005 was the first final rule. We adopted what we called foundation standards. It was basically 3 standards that were adopted. It was NCPDP script 5.0, We also adopted, at the time, NCPDP Telecom 5.1, and then we adopted the NC X12 eligibility transaction. In 2006, we did the ePrescribing pilots, where we tested some of the other standards that weren't quite ready for widespread use, such standards for like medication history, Rx fill, formulary benefit. And in 2008, from those pilots, we published another final rule where we adopted some more standards, which we called initial standards. We kind of built upon the foundation standards that we adopted in 2005. In 2009, CMS put out a HIPAA modification rule, and it's important to note in that rule, the NCPDP script Telecom 5.1 was retired for D.0, for version D.0, and they also retired the 4010 X12 standard to 5010. And so to move along with HIPAA, the ePrescribing program adopted those standards as well. In 2010, we put out an interim final rule with comment. That's kind of like a mini regulation, and in that rule, we said that business partners could use 10.6 as a voluntary use. And also in that rule, we hinted at lifting the long-term care exemption at a later date. And in the 2013 physician fee schedule, we lifted the long-term care exemption. And as you know, what we're talking about today, that exemption for long-term care, it expires on November 1st of 2014. Next slide, please. So we have when we first did the standards for ePrescribing, we had some original exemptions. We exempted certain things when physicians were doing at the time with their ePrescribing systems. One was the computer-generated fax. This is where they would, a doctor could be creating a script electronically through his computer, and then he would electronically fax it by his computer to the pharmacy. We allowed that for a time, but in January of 2012, we lifted that exemption. We no longer allow that to happen. So in ePrescribing for Part D, you have to use the script standard as the mode of transmission for prescription-related information via the dispenser to via the prescriber to the dispenser. We also exempted ePrescribing of controlled substances. At the time when we published our first final rule, controlled substances were not allowed to be electronically prescribed, because DEA has legal authority over the scheduled drugs. And in 2010, they wrote an interim final rule with comment that allowed for the use of electronic prescribing. We still have it as an exemption for ePrescribing, and because there's not a whole lot of widespread use. Normally that exemption applies to some of the ePrescribing and incentive programs that we have out there. The old the MIPA incentive programs, a physician had just prescribed so many prescription electronically in order to get a payment, and in EHR incentive program that's currently going on right now, I think the threshold is greater than 40% of the prescriptions are sent electronically, and what we call those permissible prescriptions, but we also exclude the scheduled drugs. In long-term care, we exempted that because of the way the workflow was. And in 2004, when we were developing the first final rule, the long-term care community came to us and said, we really would like to do this, but our industry is not quite ready to do ePrescribing. We need to work out some of the kinks and the way the prescription flows back and forth. And then also we exempted what we call same legal entity exemption. And what I mean by that, I always use Kaiser, like a Kaiser Permanente, which is a closed system. everything is within that single entity of Kaiser, the doctors, the pharmacies, the hospitals. It's all within that one entity. But there is a caveat to this exemption. If they're to receive electronic prescription or a request from outside their entity, then they must be able to support the standards. Same goes if they were to send something outside of the legal entity's walls, they would have to use the ePrescribing standards. Next slide, please. So script 10.6, this is one of the linchpins, I would say, of the whole ePrescribing standards. This is the transaction where the information goes from the prescriber to the dispenser. There's also some information built in within 10.script, such as medication history, where information flows back and forth from the prescriber to the health plan to get eligibility requirements, formulary and benefit copays, that kind of thing. In 2005, we adopted version 5.0. Later in 2008, we then adopted version 8.1, and then most recently, last year on October 1st of 2013, we expired version 8.1, and we have adopted version 10.6. Next slide, please. Excuse me for a second. So controlled substances, I talked about that earlier, where that is under the purview of the DEA. Scrip, the DEA has control over that. CMS starting back in 2006, 2007, we started talking with DEA about lifting the requirements of just the paper-based prescribing for the controlled substances. And in 2010, I believe March of 2010, they released a rule allowing the use of it. It's a pretty stringent rule with some of the certification requirements that go around it, and what the pharmacies and the physicians have to do. You have to single sign on. There's some encryption that has to go on, and a lot of retaining of records. But it is allowed to, it is now allowed to prescribe these medications electronically. Next slide, please. So the long-term care, we lifted that up until November 1st of 2014. Entities transmitting prescriptions or prescription-related information, where the prescriber is required by law to issue a prescription for a patient to a non-prescribing provider, such as a nursing facility, that in turn forwards that prescription to a dispenser, let's say the pharmacy, are exempt from requirements for using the script standard. But as of November 1st, that exemption will be expired. And so beginning on November 1st of this year, if you're going to be ePrescribing for Part D individuals or Part D eligible individuals, you're sending prescription related information or prescription related order, medication order to the pharmacy. It has to be done via 10.6. Next slide, please. So who's affected by this change? Well, of course, prescribers are affected by this. Pharmacies, the long-term care pharmacies are affected because they're now going to be receiving these prescriptions electronically. The long-term care facilities itself, they're going to have their EMR systems ready to go to transmit the prescription orders or electronic prescriptions by 10.6. Pharmacy software vendors, they're going to have to be able to get their systems coded in a way to allow the transmission in the transaction 10.6 to be ready on November 1st. EMR Software vendors, you know, let me just step back a minute. Pharmacy software vendors are really not much. Most of the ambulatory pharmacy software vendors are really up to speed on 10.6 and ePrescribing. And the EMR software vendors, they're going to need to be able to have 10.6 ready to go on November 1st. There's a lot of proprietary software out there in long-term care. Some may be using HL7, and they think HL7 will still be a way to send these prescriptions come November 1st. But HL7 will not be allowed under the ePrescribing for long-term care come November 1st. They're going to have to be using 10.6. And also the intermediaries, such as ePrescribing networks and some of the clearinghouses, they're going to have to be able to accept these transactions. Next slide, please. So we're going to talk a little bit about ePrescribing and long-term care. So I kind of want to give you a brief history of how we got to where we are today, and you know, why we are lifting the exemption on November 1st of this year. So it all started with ePrescribing. It all started with ambulatory standards, and in the original rule. So based on public comment in our 2004 Notice of Proposed Rulemaking, the long-term care community asked to be exempted. They said that current ePrescribing workflow would make it burdensome to their industry if we made them adopt these standards in 2005. So we listened to them, we exempted them, and then in 2006, as one of the pilot programs, we did enlist the help of long-term care. I believe it was Achieve Healthcare out in Minnesota. We did a pilot with them in a year, and they found out that they needed to use scrip version 8.1 to help get over some of the hurdles that were first presented with them. So they piloted scrip version 8.1 in the nursing facilities. What they found out as a result of these pilots, that certain messaging did work as it was presented to them. Patient eligibility, formulated benefits worked. Some worked after some retrofitting. They had to massage it a little bit with long-term care information in order to get it to work. So, some messaging needed to be invented. There just wasn't any messaging built into the standard itself, in the transaction itself, for some of the things that they needed. Such messaging was handling for open orders, resupply. In the ambulatory setting, we call that a refill, but in long-term care, it means something else. So as a resupply had to be created. They really needed census information for their business model, and that wasn't available. And there was also rarely used messaging that was proved critical in long-term care setting, such as fill status notification and the fill cancel, Rx cancel. So with that, we with all those changes that we uncovered in the pilot, NCPDP work group, I believe it's work group 11, long-term care folks and industry got together. They started creating and building these transactions and these message types. And as a result, we got to NCPDP script version 10.2 or higher was able to handle these workflows. And then July 10, I published an IFC, which is it's an interim final rule of comment, and based on public comment, I think long-term care, some of the folks in long-term care really want us to lift the exemption back then. But however, I couldn't do that for regulatory reasons, because 10.6 was voluntary use. We hadn't adopted it, but we did hint that once we finalized 10.6 as an adopted standard for ePrescribing, we would be lifting that exemption. And so in calendar year 2013, in the physician fee schedule, which is the payment rule that comes out every year out of CMS, based on industry comment again, they wanted us to lift the exemption. There were some fears that they're going to be left behind. There was fears that there's going to be all these proprietary systems out there that weren't going to comply. It was just going to make things worse. And so based on that comment, CMS lifted the exemption, and based on industry and commenters' recommendations, we made that effective on November 1st of 2014. Next slide, please. So physician order. So what do we mean by that? So are physician medication orders considered prescription or prescription-related information and therefore subject to the e-prescribing standards for Part D? Well, the answer is yes. A physician's medication order serves as the same thing as an electronic prescription or as a prescription that would get sent to let's say, a Walgreens or CVS. It is subject to the same federal regulations regarding e-prescribing for the e-prescribing Part D program. Next slide, please. So point of care to dispenser, our verbal physician orders that are transcribed by a long-term care facility into a long-term care EMR, EHR system, excuse me, and then transmitted electronically to the dispenser. Are these subject to e-prescribing regulations? Well, the answer is yes. E-prescribing includes, but not limited to, two-way transmissions between the point of care and dispenser. So, e-prescribing just doesn't happen between the prescriber, the doctor in the office, or in sending it to the pharmacy. That's the typical two-way transmission that most people envision e-prescribing. But in long-term care, there's a three-way. It could be a three-way transmission. It could go from the physician to the facility, and then the facility passes it on to the pharmacy, the facility's pharmacy. So that becomes a three-way transmission. So the e-prescribing rules do apply. Next slide, please. So how's it done today in long-term care? Well, right now they do some HL7 messaging. There may be some proprietary stuff that's point-to-point. There's the NCPDP scrip standard and computer-generated facsimile or computer-generated faxing. All except the NCPDP script version 10.6 will not be allowed. I think sometimes when we use non-compliant, it has a different meaning in the long-term care setting and some of the other settings. But so I kind of want to make that point clear. It won't be allowed, and it won't be an allowed solution beginning November 1st. So the only thing that's allowed under the program would be the script version 10.6. Next slide, please. So we have alternatives to e-prescribing. There's the traditional prescription pad, and as we saw in some of the slides earlier that Gary was presenting, a lot of the physicians are moving towards electronic prescribing, and they're moving away from the prescription pad. There's the telephone or verbal order from prescriber to dispenser, and then there's manual fax. These are some of the ways that are happening today in long-term care. I've just noted that when November 1st rolled around, manual faxing of a prescription is not going to be allowed as electronic form. But these are alternatives to e-prescribing, and will still be allowed. I mean, the e-prescribing program is a voluntary program, so to speak, when it comes to prescribers and dispensers, but however, the health plans, the Part D plans, they are required to support the standards. So, what that means is that there's one prescriber or one dispenser that wants to prescribe, and it's for the whole network for that Part D plan. They have to have these in place, and so which then trickles down to the vendors. The vendors are going to have to be able to support this, because if the plans have to support it, the plans can go in and later on and make sure that these transactions are happening, because that they are on the hook for this. The next slide, please. So what's consequences of non-compliance? So everyone if they're not compliant, so let's see if they're not following the standards. So you could have administrative and efficiency issues. There's studies that have shown where ePrescribing has greatly improved efficiencies with prescribing. In the doctor's office, there's been some improved efficiencies. In the pharmacies, there's been improved efficiencies. It could reduce standards of care. There's a lot of information that goes on with ePrescribing, such as med history, formulary and benefit, and copay information, and then non-compliance with regulatory requirements can become an issue if you're not prescribing for Part D beneficiaries using the standards. Physicians, some consequences for the physicians, they could mean loss of incentive opportunities. As I spoke to before, there's a few CMS incentive programs currently going on where physicians, eligible physicians and eligible hospitals can receive incentive payments, and and there's a requirement to receive those incentive payments to be electronic prescribing. There can be reimbursement penalties. And with these incentive programs, there can be audits. So in the EHR incentive program, we do audits of the providers who are claiming to be meaningful users, and we can go in and we check to make sure that they have station. And so, for example, on the electronic prescribing measure, they have to prescribe greater than 40% of their medications electronically. If the auditor goes in and finds out that they have not done so, they can recoup money. And part of the certification for the EHR is that they're using the Part D standards. Next slide, please. So for the EMR software vendor, not using the standards or not providing the standards for Part D equals dissatisfied customers. Your customers are going to want to be able to participate in any incentive programs if they're eligible for it. And in order to do that, you have to be certified product, and in order to get certified, you have to use the standards. You also have to be certified on some of the ePrescribing networks where they won't allow the transmission won't go through if you're not on a certified system, and some of the ePrescribing networks look to see if you're compliant with all the Part D standards and transactions. Pharmacy, a problem could be reimbursement. If you're doing electronic prescribing and you're receiving electronic prescriptions, a Part D plan could come in and do an audit. And in that audit, they can look at all your ePrescribing prescriptions and the payments, and if they find that you are not using the standards, they could recoup that money. For long-term care facility, you have financial responsibility, residents' financial responsibility. ePrescribing has some things where they can look at copay information. There are certain, you can look at med history, and a lot of eligibility information that goes along with ePrescribing. And it could disrupt operational due to reverting back to traditional alternatives, like I said before, using manual fax, paper prescriptions, doing all your med orders over the telephone. Next slide, please. So with that, I'm going to hand it back over to Gary, and he's going to talk about some of the next steps.
Okay, thank you, Drew. I want to take just a couple minutes to talk about next steps for our industry. First of all, for long-term care facilities, reach out. Next steps would be to reach out to both your servicing pharmacy and also your EMR software vendor, and basically inquire as to their individual states of readiness for either transmitting or receiving electronic prescriptions via NCPDP scrip standard. And for this to work, both sides of that transmission are going to have to be ready to go. So that would be next steps for the facility. Certainly software vendors, whether that be the software vendor for the pharmacy or the vendor for the EMR in the nursing facility, will both need to have their software compatible and ready for script version 10.6 messaging on November 1st. And certainly pharmacies then also would want to reach out to their software vendor and inquire as to the state of readiness for their individual software vendors. Next slide. Just listed here a couple sources of information, reference sources, certainly the Federal Code of Regulations, and specifically for this topic, it's sections 423, 159, and 160. The CMS and CMS website. Also, information about the NCPDP script standard is available on NCPDP's website. Next slide, please. Okay, got a few post questions here that we need to run through for CE compliance. First of all, when is the current exemption for long-term care to use the NCPDP script standard to transmit electronic prescriptions for Medicare Part D set to expire? And the answer to that is B, November 1, 2014. Second question, which of the following transaction standards were named as foundation standards for the Part D ePrescribing program? And the answer here is the script standard, NCPDP Telecom, and the ANSI X12, 270, 271 were all foundation standards. I think foundation is the key word in this question. They were the original standards, and then subsequent to that, the NCPDP medication history was named in the most recent rule. True or false? Once the exemption is lifted for long-term care, facilities will still be able to use HL7 messaging to transmit electronic prescriptions for Part D eligible beneficiaries? And the answer to that, of course, is false. Number 4, which of the following are not allowed under the Part D ePrescribing program for long-term care? And as Drew covered, that would be computer-generated faxes. Also, HL7 messaging would also not be allowed after November 1. And lastly, true or false, are physician medication orders considered prescriptions or prescription-related information and therefore subject to the ePrescribing regulations? And the answer to that, as Drew described, is true. Okay, that completes our prepared comments. And Wendy, if you want to just, I guess, share the questions that have come in over the chat line, and we will answer those as you read them out.
Okay, thank you, Gary. Our first question today, what are the penalties to EHR vendors if they are not sending script-based order messages on November 1?
So this is Drew at CMS. Well, the ePrescribing program that was created under MMA in 2004, there are no enforcement. I have no enforcement of using that. So there are no government monetary penalties. The penalty could be that you lose, would lose customers, because if you're not going to program to allow for ePrescribing under the Part D program, if I was you would probably lose customers, and they would find solutions that were that were able to do so.
Okay, our next question. Are there other penalties to the long-term care pharmacy for receiving HL7 messages after November 1st, other than the potential for non-reimbursement?
like I said before in my last question, there are no, I have no enforcement. If you receive HL7 messaging, that messaging, you can still receive it, but like I said before, the only thing that could happen would be under audit. A plan could come in and audit you, and they could recoup money.
Okay, our next question. Will the pharmacy be required to obtain new 10.6 prescriptions annually to indicate that the prescriber has certified an ongoing order for another year?
Can you repeat that question, please?
Will the pharmacy be required to obtain new 10.6 prescriptions annually to indicate that the prescriber has certified an ongoing order for another year?
So the 10.6 is not a prescription, so to speak. It is a transaction. It's an electronic transaction that carries the prescription-related information. So right now, and as of October 1st of 2013, we have adopted 10.6 as a transaction for e-prescribing, and then come November 1st of this year, the long-term care are going to be doing that. So until we adopt a higher version of script, and that's a possibility because we have adopted, we're on our third version of script in this program. Until we adopt the next version, then 10.6 is the adopted transaction. So, it's, when I talk about certification for like the EHR incentive program, we're certifying the software, that we're certifying the vendor's product that has that transaction in it. So, as a prescription, if every year if you need to renew a prescription, then that is a business model. That's well, I guess what I'm trying to say is that the 10.6 is not the prescription itself. It's just a way of transmitting the information from the prescriber to the dispenser.
Right.
Okay.
Drew, this is good. I just jump in real quick. There's nothing in this rule that changes any of the existing timelines as far as requirements for new or reconfirmed orders from the prescriber or anything like that. Whatever's in existence today will continue to be in existence, and whether that's something that's at the federal level or at the individual state levels, there may be some variation, but there's nothing in this rule that is going to change any of those type of timeline requirements.
Okay, our next question. Drew, can you please clarify what CMS deems as an acceptable three-way transmission from point of care to pharmacy when communicating a prescription to a pharmacy? For example, is this an acceptable process for a non-controlled medication? 1, the nurse receives a verbal telephone order from a prescriber. 2, the nurse transcribes the verbal prescription order into script 10.6 e-prescribing system. 3, then the nurse transmits the script 10.6 prescription order directly to the provider pharmacy.
So okay, so if I understood correctly, so they receive a verbal order from a physician, and then the nurse in the facility then takes that order and they transcribe it within their EMR in the e-prescribing module, and then they send that prescription electronically using 10.6 to the pharmacy as an electronic prescription. That would be allowed because they are sending prescription-related information via 10.6, and you have to remember the nurse a lot of times acts as the agent of the physician in this case, so she's just acting on physician's wishes to have that medication filled. The same thing happens in the ambulatory world. I've been in some doctors' offices where the doctors, they have the nurses up front send electronic prescribing, the prescription to the pharmacy of choice, because they're acting as the agent of the physician in that case.
Okay, our next question. As of right now, we are receiving hand faxes from the nursing homes. Will this still work, or do we need to start the ePrescribing?
Currently, if you're doing it today, you can still do that. On November 1st, or at 12:01 on November 1st, you're going to have to be doing that electronic prescribing because manual faxing is not allowed under the program. And you have to remember, when I talk about electronic prescribing, we're talking about for Part D eligible beneficiaries.
Okay, our next question. On their website, Rxnorm states the following: over-the-counter medications will be added and covered when reliable information about these medications can be found. What should LC do about prescriptions for over-the-counter medications? What should LC do?
Well, currently electronic prescribing under the Part D program, OTC medications are not one of the, they kind of fall in the realm of the, well, OTCs, we don't consider those as prescriptions, so to speak. So, I mean, and also the long-term, the ePrescribing program has not adopted Rxnorm, so that really falls outside of our purview and what we're talking about. But currently, with over-the-counter medications, there's not a whole lot that's being prescribed electronically, and we haven't come down on either side on that issue in the regulations.
Okay. Our next question: is the pharmacy still permitted to share dispense data of an e-script received from the prescriber to an EMR through HL7 and a secure connection?
If they mean by secure connection, are they going through a network, or are they doing point-to-point? Is there any way we can have that person ask that question clarify? If it's the case of point-to-point where they're doing a direct messaging, they're going to, it is for ePrescribing for Part D eligible beneficiary, and then it's going to have to be the scrip standard. Come November 1st, HL7 is not going to be allowed in the long-term care setting. The only time HL7 is allowed if it's if it's a single legal entity. That's important to remember.
Yes, she did say point-to-point.
Okay.
Okay. Next question. Will the following workflow be compliant after November 1st? A physician e-prescribes an order via script 10.6 to the pharmacy. The pharmacy receives the order for dispensing. The pharmacy system sends an HL7 message to the nursing home EHR to populate the electronic medication administration record with the medication order.
Okay. So from what I think they're saying here, so a physician prescribes a medication, sends it to the pharmacy. The pharmacy then fills that prescription under Part D. That part is that's allowed under the program, and so then the pharmacy is turning around and sending an HL7 message back to the AMR system. So my thinking there is that they're alerting the facility that they had filled this medication and they want to update the patient's record. That, I believe, would still be allowed because they're not. The prescription's already been filled, and that whole that's been taken care of. They're just sending messaging back to update the EMR.
Our next question. In your opinion, will faxing of orders go away completely?
You know, for e-prescribing, faxing of orders have gone away. I can only speak to the e-prescribing program and the legal authority that I have in adopting standards. Whether to say that ever happens, I can't say.
Hey Drew, this is Gary. Drew, one point of clarification I would like for folks on the line has to do with manual faxing.
Okay.
If the facility is and this is my understanding, and if I'm wrong, you can tell me I'm wrong, but if the facility takes a piece of paper and manually puts it through the fax machine to send an order to the facility, or excuse me, to the pharmacy, that by CMS interpretation, that is not e-prescribing and therefore would not be required to be 10-6, and they can continue to do that.
Yeah, what you're saying, yeah, so if they're manually faxing a prescription to the pharmacy, that is not allowed under e-prescribing, and so the only allowed way to do that is correct, would be through 10.6.
Okay, but my point of clarification here is that is not e-prescribing.
You're correct, that is not e-prescribing.
But
manual faxing,
But does the rule tell them they can no longer continue to do that at all? As a manual process.
Yeah, that's a manual process, and I think they're in the rules we talk about a manual process not being allowed. I'll have to go pull that. I have to go pull that reg and pull that piece out, but I do believe we do state that, and that's probably in the first rule in 2005.
Okay, our next question. Does this apply to group homes, assisted living facilities, or just skilled nursing facilities?
That's a good question. I mean, it's all on how they're set up. I mean, if there's prescribing going on in the group homes, and there's, I believe it's probably, I'll have to get clarification on that one. I don't want to speak and give out wrong information. But that's a good question. I'll research that.
Okay. Is there a contingency plan for telecom system interruptions locally or regionally due to a natural disaster, let's say?
That I am not the person to answer that question. That is so I really wouldn't. I don't have the expertise on that piece, but so.
Does the 40% e-prescribing requirement for physicians include prescriptions for all their patients, Medicare Part D patients only, or Medicare long-term care patients?
So the way the measures work is there's a numerator and denominator. So the denominator is your patient base, and then the numerator is the number of patients that you send a prescription electronically. So that has to be greater than 40%. There are some exceptions or exclusions to that rule. If you're prescribing less than 100 prescriptions, in the reporting period, you can be exempt, as well as some physicians who are primarily prescribing controlled substances. They may have a hard time prescribing what we call permissible prescriptions.
Okay.
But the incentive piece is off their Part B claims. It's paid through their Part B claims. So they get the incentive, and so when the payment adjustments hit, they adjust Part B claims.
We have a few residents that use local pharmacies and not our institutional pharmacy. Are we required to use electronic prescribing to the other outside pharmacies?
Yes, you are. If you're sending so it sounds like they're trying to say they're in a closed system. So if you're sending that prescription to the patient's pharmacy of choice, say the independent down the street, that's not part of your facility, then yeah, that has to be sent electronically using the standards. And at the same time, if that pharmacy is then sending a message back to you asking for a refill or a change or a cancellation, you have to be able to accept that messaging, ePrescribing transaction messaging.
Our next question. There appears to be very little movement toward long-term care facilities being able to receive electronic prescriptions from the prescriber. Do you eventually see movement in that direction? And are they exempt from the standard?
I'm sorry, can you repeat that?
There appears to be very little movement towards long-term care facilities being able to receive e-scripts from the prescriber. Do you eventually see movement in that direction, and are they exempt from the standard?
They will not be exempt from the standard if they're having difficulty receiving prescriptions by the physicians. But I wouldn't be surprised that you would see more movement of more and more physicians being able to connect with the long-term care facilities. And back in 2009 when we did the first ERX incentive programs, that's where we saw the greatest jump in adoption. So, once people get up to speed and get the standards adopted in their workflow, I don't see where you wouldn't see more and more scripts on a daily basis.
Okay, our next question. After November 1st, will e-prescribing of controlled substances be required, or can the physician's office still fax those orders?
I'm sorry, Wendy, you're cutting out on me. Can you repeat that?
After November 1st, will e-prescribing of controlled substances be required, or can physicians' offices still fax those orders?
So under the program, under the e-prescribing program for Part D, you can certainly, if you are certified and if you have done all the requirements that the DEA has laid out in their rules to electronically prescribe controlled substances, you can still send it that way. If your system is not able to do so, currently you could still you can still do paper faxing, or not paper. I'm sorry, not paper. You can still do paper prescriptions, or on the alternative methods of getting that medication dispensed. Because as I said before, CMS does not have legal authority over controls. That falls under the purview of the Justice Department and the DEA. So I can take maybe one more question, and we can wrap this up. But I also want to put out there, any question that we have not gotten to, I will have them emailed to me, and I will, I can respond to these. But I can take one more question, Wendy.
Okay, our last question. Just to clarify, I have heard two different answers regarding acceptable alternatives to the 10.6 e-prescribing. If I receive a manually written prescription via fax from a group home, will it be subject to non-compliance with electronic prescribing?
So as I said, no, you don't need to read it again. It's just another way of asking an earlier question. So manual faxing is not allowed. Currently, under the ePrescribing program. And so when November 1st rule comes around and the exemptions listed for long-term care, and I think I did say I have to go back and look at, see where group homes fall into this. Manually faxing, paper fax, manually faxing something to the pharmacy for a prescription for a Part D beneficiary or eligible beneficiary is not going to be allowed.
Okay. Thank you, Drew and Gary. That concludes today's NCPDP webinar, Preparing for the Medicare Part D Requirements for ePrescribing and Long-Term Care. We would like to thank Millennium Pharmacy Systems, Inc. for sponsoring today's webinar. Remember to return CE evaluation forms you will receive via email after the webinar by Tuesday, June 17th. You can also email any additional questions on today's topic and reply to the follow-up email you will receive after the webinar today. Any questions that were chatted that we did not get to today will be addressed via email. Thank you for joining us today, and we look forward to having you at future NCPDP educational programming. Have a good day.